It's my pleasure today to introduce Dr. Asreb. Some of you may have known him. He started here early as one of our first class of residents in the internal medicine residency. But by way of background introduction, Dr. Asreb graduated from the University of Florida in the United Arab Emirates. He completed his residency, as we mentioned here at Northeast Rhoda, internal medicine program. He's very passionate about advanced imaging and integration of this preventive cardiology. And he'll be graduating in a few months, and we'll be moving on to
Kansas City
practice
faculty.
Excellent. So we'll invite him to the stage to give us his presentation today. Ben.
Awesome. Thank you, Dr. Egelam, and thank you for everyone who is attending in person and online. My name is Abdullah. I'm one of the third-year cardiology fellows here. And today my grand presentation is going to be about the use of advanced cardiac imaging in the field of cardio-oncology. And also I'm going to brush up on some of the cardioprotective therapies that we can use for cancer survivors and for patients who are on chemotherapy. I don't have any financial disclosures for today's talk. My learning objectives are going to be, one, to know how to define and accurately diagnose what is known as cancer therapeutic related cardiac dysfunction, and also explore the scope of cardiotoxicity. Also to review the prevalence and identify who is at risk and who should be closely monitored while being on chemotherapy. The main bulk of my talk will be to illustrate the role of cardiac imaging in early detection of cardiotoxicity. I'm going to be going through echo, cardiac MRI, nuclear imaging, and cardiac CT. And then lastly, I'm going to spend some time talking about some of the cardioprotective strategies that have been approved in guidelines and how can we implement them. In 2026, it is expected that in the United States alone, there will be over 2 million new cancer cases. And as we know, the field of oncology and chemotherapy is constantly evolving. The mortality rates have been reduced due to those advancements. But it is very important to keep in mind that those patients, despite doing better from an oncology standpoint, they very often have other consequences. And chemotherapy-associated cardiotoxicity remains as a leading cause of long-term morbidity and mortality. So it is important for us as clinicians to collaborate with all the health system personnel, including oncologists, and also with the patients to navigate ways where the patients can benefit from the oncology therapy and be cardiovascularly safe as well. This is a graph that was published in the European Journal of Heart Failure in 2020. And as you can see here, that the effect of chemotherapy and radiotherapy is extensive on the cardiovascular system. And not only it affects the heart from the cardiomyocyte damage standpoint, leading to heart failure, but it can also lead to arrhythmias, it can lead to valvular disease, pericardial disease, and coronary artery disease, along with hypertension and thromboembolism. But for the sake of time and for the sake of today's presentation, I'm going to be primarily focusing on anthracyclines and HER2 targeted therapies and the risk of developing heart failure and cardiomyocyte damage. According to the American Society of Echo and the European Association, cancer therapeutic related cardiac dysfunction is officially defined as a decline in the left ventricular ejection fraction of greater than 10%. To an absolute value of less than 53% on cardiac imaging. When a patient gets an echo at the baseline and their EF is, let's say, 65%, and then upon repeat, their EF drops down to 50, then that would qualify them as cardiac therapeutic related cardiac dysfunction. But the hope for today's talk is to help us utilize cardiac imaging to prevent that drop from happening and detect the patients who are at risk earlier. Earlier in 2014, same societies, they have divided cardiotoxicity into 5 types. Type 1 and type 2 tends to be the more commonly spoken about and identified, but it is also equally important to be aware of type 3, 4, and 5. Type 1 usually is an irreversible myocyte damage that is dose-dependent, and a common example for that would be anthracycline therapy. Type 2 is a reversible myocyte damage that is dose-independent, and usually the cardiac dysfunction will resolve with the cessation of treatment. And a common example for that would be trastuzumab that we commonly use for breast cancer. Just to be aware, type 3 is coronary disease due to radiation and vasospasm. Type 4 is miscellaneous type, such as myocarditis and Takotsubo. And lastly, type 5 will be everything else that can lead to cardiac dysfunction, including conduction abnormalities and hypertension. Moving on to the second learning objective, which is review the prevalence and identify patients who are at risk. We all know any disease in medicine, any disease process kind of follows the multiple hit hypothesis, where patients can have predisposing factors such as genetics, environmental factors, socioeconomic factors, and then they get hit with another risk factor. In this case would be cancer therapy, and ultimately develop cardiac dysfunction. So what you want to look in patients is those risk factors that we can modify. So patients who have hypertension, hyperlipidemia, diabetes, you want to identify these patients and treat those modifiable risk factors because those patients have already reduced cardiac reserve. And so when you add another stressor such as chemotherapy, then these patients tend to be at a higher risk of developing cardiotoxicity. And why is early detection is important? As you can see here from the graph is that cardiotoxicity and cardiovascular risk is the highest at the first 1 or 2 years. And it usually declines as the course goes on. But it's important for us to detect those patients early on in the disease process to help prevent cardiotoxicity. All right, so my first modality that I'm going to be talking about will be echocardiography. According to the American Society of Echo, the recommendation for a comprehensive cardio-oncology exam will include your standard TTE, which follows the ASE guidelines. So you'll get the long axis, short axis, apical 4-chamber, 2-chamber, 3-chamber views. And then on top of that would be to obtain a 2D global longitudinal strain. And I'm going to be talking a little bit in more detail about that in a second. The preferred method to obtain ejection fraction is actually 3D per guidelines now. But if that is not feasible or if it's not available in the health system for any reason, the recommendation is to use biplane Simpson method instead. And with any modality in medicine, you always want to compare the strain and the EF to any previously used cardiac imaging. All right, global longitudinal strain. It has been extensively studied to detect early changes in the LV contractile function in patients who are undergoing cardiotoxic chemotherapy. Usually what it does, it assesses how good the heart muscle is shortening. And so you would assess the length of the heart muscle at end diastole and then at end systole, and then divide that to give you a percentage. And it's usually calculated by speckle tracking echocardiography, which, like I said, measures the longitudinal shortening of the LV ventricle from the base to the apex. And then the number that will be produced will be in the negative form. And so a normal range of the LV global longitudinal strain will be -17 to -18%. And the more negative the number, the better it is. But as cardiologists and as clinicians, the number that we will be looking at to alarm us for patients who might develop early cardiac dysfunction is a drop of 15% or greater than that. In the global longitudinal strain. And the 15% is not an absolute value, it's a ratio of the initial GLS to the one that is done after. This is how you can utilize GLS. This is a case of a 67-year-old female who had breast cancer and was treated with trastuzumab. As you can see here at baseline, her ejection fraction was 63% and her GLS was 21%, which are perfectly appropriate to start the chemotherapy agent at that time. 6 months after that, the patient was still feeling fine, and she had an echocardiogram which showed her EF to be still reasonably okay. It was 57%, but you can see that her GLS had dropped from 21% to 16%, and when you calculate the delta, that is equivalent to 24%, which according to our guidelines should alarm you to early contractile dysfunction. Despite that, she was not started on any cardioprotective therapy, and then 3 months from that point, her EF dropped down to 47%, which, according to our initial definition, qualifies for CTRCD or cancer therapy-related cardiac dysfunction, hence highlighting the importance of paying attention to the GLS rather than just the ejection fraction alone. When we talk about GLS, one noteworthy trial would be the SUCCOR trial. This was a rigorous prospective controlled study to assess patients who had been on chemotherapy, and they divided the patients into patients who were treated with EF-guided cardioprotective therapy versus GLS-guided CPT. And they found out at 1 year is that the incidence of developing cardiotoxicity was much less in the GLS-guided group compared to the EF group. That was 6% versus 14%. Also, patients who were treated with the GLS-guided arm, they were twice as likely to be started on cardioprotective therapy at the right time. And then they were overall associated with a lower, although not statistically significant, incidence of reduced lower ejection fraction. However, when they followed the patients up after 3 years, they found out that there was no significant difference in the EF between two groups. But in summary, it concluded that the patients who receive cardiotoxic therapy can be either on both GLS and ejection fraction guided therapy. And the 3 years statistically did not really show one method that's preferred over the other. But the clinical numbers and the absolute numbers, when you look at them, show that there's a little bit more favorable outcome for GLS. It also did not result in worse outcomes, and in my opinion, it provides a viable and a potentially useful way to predict early cardiotoxicity. How do we incorporate GLS in guidelines? Like I mentioned earlier, if the EF is less than drops by 10% to less than 53%, then that automatically qualifies for a cardiovascular consultation. But if we use GLS, then we're looking at a greater than 15% drop in change from baseline. In Europe, they use a little bit more personalized approach. So they divide patients based on what cancer therapy they're on, if it's an anthracycline or a HER2 therapy. And they subdivide patients based on their risk. So the higher the risk, the more frequent the monitoring process is going to be. Left atrial strain is another emerging parameter that we have been, constantly learning about and improving in cardiology. And it kind of uses the same concept, which is assessing the deformation of the left atrium and assessing the left atrial compliance and function. It is usually divided into a reservoir, a conduit, and a contraction phase. A reservoir coincides with ventricular systole, conduit is with ventricular diastole, and contraction is with atrial systole. And the most commonly studied and used information will be the left atrial reservoir, and it essentially assesses the left atrial compliance and diastolic function and filling pressures of the left ventricle. But despite that, it has not been officially documented as part of the guidelines in cardio-oncology, but there have been several meta-analyses and systematic reviews that proved that left atrial strain at some point will have a role in cardio-oncology practice. Cardiac MRI, this is another modality that is extensively used in cardio-oncology. In fact, it is, per guidelines, the gold standard non-invasive test to assess the ejection fraction and also assess the chamber volumes. It can detect subtle changes in the ejection fraction and the LV volumes, so it can also help you assess clinical symptom, assess CTRCD early enough in the course to start cardioprotective therapy. Strain in cardiac MRI is also a thing like it is in echo. There are two common ways that can be utilized to do that. One of them is the tissue feature tracking, which is dependent on speckle tracking, similar to how we do it in echo. And it usually requires high resolution images, more points to track, but like like echo, it gives you a number here where it will tell you how negative the strain is, and you can use that to help guide your management. The other method that can be utilized is strain-encoded strain in cardiac MRI, or SENC. This is a more robust, more clinically relevant, and is the one that we currently use. The only problem with that is that it requires a more sophisticated process of processing, and requires a dedicated sequence that is more complex, while the other one is more simplified and requires just the basic images. Tissue and scar characterization, while it does not necessarily give you an exact diagnosis of CTRCD, it is helpful to identify whether there's ischemic or non-ischemic origin of cardiac dysfunction. And so what we look at in those patients is the late gadolinium enhancement, which is this hyperdensity that you see here in the heart muscle. So this is the left ventricle, this is the right ventricle, and usually in a normal case, it should be uniformly black color. But then when you have this late gadolinium enhancement here in the heart muscle, this is when you suspect that there's an issue going on. If you have an ischemic origin, so let's say there's an RCA occlusion, or like in this patient, you will find here that there's a subendocardial late gadolinium enhancement in the inferior wall. This is a transmural LG. This is for a patient who had an infarct in the septum, and that tells you that this is more of an ischemic origin. Non-ischemic origin pattern will be more so subepicardial and mid-myocardial late gadolinium enhancement. And the reason this is important is because if you have this in combination with someone who has been on chemotherapy, then that would guide you that this is probably chemotherapy-related cardiac dysfunction. But if you have a patient who is on chemotherapy and then have ischemic origin, then that would point you towards assessing other reasons for why their ejection fraction is reduced. So overall, it just gives you valuable information about why their ejection fraction had dropped. Also allows you to assess for infiltrative diseases like amyloidosis, sarcoidosis. So it's a very valuable tool overall. The next parameter is T1 mapping and ECV assessment. In simple words, ECV is extracellular volume fraction mapping, which essentially measures how much fluid is there in the heart muscle or extracellular space. So that will include collagen and fluid. Normally, the normal number for that is about 20%, 20 to 30%. But as you can tell from any other inflammatory process, when you have inflammation, there's always swelling, there's always more fluid produced. And so when someone has been exposed to chemotherapy, the heart muscle will undergo some sort of inflammation, and the extracellular volume will increase. And so the higher the number, the more likely that patients have suffered from cardiac dysfunction due to that. In an old study in 2013 that was published in the Journal of Cardiac MRI, they assessed the extracellular volume to two parameters. One of them was anthracycline dose, and the other one was for peak VO2, or the exercise capacity of those patients. They found out that the higher the anthracycline dose used, the higher the ECV numbers were. So as you can see here, the higher the anthracycline dose utilized, the higher the ECV percentages. And then the higher the ECV percentages, the lower the patient's exercise capacity is. So overall, a great way of helping identify cardiotoxicity earlier in the disease process and initiate therapy. In guidelines, cardiac MRI comes second right after 3D ejection fraction, and that is simply because echo is a lot more available, and the healthcare systems are usually more comfortable with echo than cardiac MRI. And so 3D echo comes in as the first method of assessing ejection fraction, then cardiac MRI if for any reason 3D is not available or it's non-diagnostic. If cardiac MRI is not available, then the next step would be to do the 2D simple biplane method of assessing EF. And then the last resort would be to use the multi-gated analysis scan, nuclear scan. A few words about immune checkpoint inhibitor myocarditis. Those are newer agents that are proving to have promising results in different types of cancers. But what's important to keep in mind with those patients is that there's always a risk of immune checkpoint inhibitor myocarditis. In the past year alone, I've seen here 6 or 7 cases, and cardiac MRI plays a very important role in detecting that condition, because appropriate early therapy with steroids is very important. The criteria that we should all be aware of is Lake Louise criteria. I don't know why it was called this way, but there are 2 main criteria that you rely on. There's T1 and T2 based findings. T1 is basically looking at your late gadolinium enhancement, ECV, like I mentioned earlier, that looks at non-ischemic myocardial injury. And then T2 mapping will look at your myocardial edema. And once patients satisfy both criteria, then that would qualify them for the diagnosis of immune checkpoint inhibitor myocarditis. Other supportive criteria would be to look at pericarditis or if there's any pericardial fluid. And then an added bonus point would be if there's any systolic LV dysfunction. The third modality is cardiac CT. Cardiac CT is a great non-invasive way to look at the coronaries, to look at the structures of the heart, look for any congenital changes. But it has a limited value in assessing the LV systolic function. Hence, it was not part of the guidelines as to where you could utilize it for ejection fraction assessment. But it's also equally important because, like I said earlier, patients can have 2 coexisting disease process happening, chemotherapy and obstructive coronary disease. So you can utilize cardiac CT to detect both obstructive and non-obstructive CAD. Also, patients who have had radiotherapy, their highest risk is to develop valvular disease, but they can also develop coronary artery disease and pericardial disease as well. This is a cross-section of a cardiac CT here. You can see that this is the heart, and this is the rib cage, the aorta. And if you can look closely here at where the pericardium is, it usually should not be this hyperdense. Anything that looks super white and look in a similar intensity to what the bone looks like, that is usually calcium. And that's a calcified pericardium that is due to radiotherapy. This patient presented with constrictive pericarditis, which could be mislabeled as just regular diastolic heart function, and the treatment for this is usually a pericardiectomy. Similarly, radiotherapy can lead to coronary artery disease. This is a cross-section of the heart here. This is the aorta. This is where the left ventricle is, the right ventricle. And you can see here that this is the left anterior descending artery traveling in between the 2 ventricles. And you can see here again the white calcifications that are at similar intensity to the bone, indicating that this patient developed CAD. And then this is a little bit of a higher section here, lower section. You can see here that this is the aortic valve and it's extensively calcified. Those patients can end up with significant aortic valve stenosis. So overall, the cardiac CT has a more of a role post-therapy or post-radiotherapy, but again, very important in assessing the coronary tree as well. A few words about nuclear imaging. Earlier in the day, several years ago, multi-gated acquisition scan used to be the gold standard for assessing ejection fraction, but this had fallen out of favor compared to other modalities because we have more accurate ways of assessing ejection fraction. But still, it's worth knowing. And also, some of the studies have actually used this method of assessing ejection fraction when it comes to cardioprotective therapies. And then the other benefit for that is for SPECT and MPI, or SPECT and PET-CT. Those are useful tests in detecting subtle ischemia, assessing the MBFR to assess for microvascular dysfunction as well. So those are the two primarily functions for nuclear imaging and cardio-oncology. I'm going to spend the last few slides talking about cardioprotective therapies. In literature, the agents that were used were beta blockers, ACE, ARBs, statins, and dexrazoxane. Beta blockers have been extensively discussed in heart failure therapy. They're one of the heart failure with reduced ejection fraction pillars of treatment. And so that was also studied in the field of cardio-oncology as well as an early protective method from developing cardiotoxicity. This is an older study back in 2013, but they divided patients into taking beta blockers versus not taking beta blockers, and they monitored them over a 5-year span. And as you can see here, that the incidence is much less for patients who were started on beta blocker therapy compared to not taking beta blockers. And you can see here from those numbers here that the incidence is a statistically significant difference. So overall, a very favorable outcome for beta blocker use in cardioprotective therapy. ACE ARBs have been also extensively used. As you can see here, there are 6 studies. There are even more. But the overall outcome for those studies is kind of, the primary outcome was always that it did show that there's a reduction in the incidence of in heart failure and attenuation of the reduction in heart failure when you use ACE ARBs. But when they followed them up over years in most of those studies, they found out that patients have not actually had a significant difference in the ejection fraction. But if you think about it, most of those patients who have coexistent hypertension, ACE ARBs tend to be the most commonly prescribed medication for that. So overall, it did not lead to a worse outcome, but not necessarily a significant benefit. But there are some findings here that did prove that they do help with reducing the incidence of heart failure. So overall, I would say that they do have a role in preventing cardiotoxicity. Statins, we all know them for their cholesterol-lowering property. They are believed to have another effect. They indirectly inhibit key regulators that have been shown to play a role in developing anthracycline-induced cardiomyopathy. And in 2022, in Europe, the guidelines give them a Class 2A recommendation for the primary prevention of CT-RCD, and that is primarily for patients who are at high risk and very high risk category. Dexrazoxane is an iron chelator, which is an EDTA derivative. It reduces the production of free radicals in patients who are on anthracycline therapy. The only approved use for dexrazoxane is for patients who have metastatic breast cancer, when the equivalent dose is greater than 300 milligrams per meter square. But the reason this is not commonly used, or we probably have not heard of, is because those high doses are now rarely used, because we have constant other new therapies that are being used. And also some studies have shown that dexrazoxane actually increases the risk of other types of cancers. Hence, it is not commonly used and fallen out of favor. So how can we mitigate cardiotoxicity, and how can we help patients who are on cancer treatment? I'm going to spend a couple of minutes on this chart here that was published in JACC. So the first thing is, obviously, you want to come to the diagnosis. Let's say the patient had a drop in their EF and their EF is less than 53% now. Then the first thing we need to do is treat any underlying conditions. Treat their coronary disease, treat their hypertension, if they're diabetic and poorly controlled. You want to control any disease process that can potentially affect their ejection fraction. And then the next step is to stratify that to either symptomatic or asymptomatic. So if they're asymptomatic, they still qualify for CT-RCD. They still need to be seen by a cardio-oncologist, and they still need to be started on cardioprotective therapy. But then the subdivision will come into if their EF is less than 40% or more than 40%. If their EF is less than 40%, then the recommendation is to hold the cancer therapy, do regular physical exams, TTEs, BMP, NT-proBNP, and then at some point, if the EF has increased or returned back to where it was, then the recommendation is to discuss potentially reinitiating the cancer therapy. Now, if their EF is more than 40% and they're on anthracyclines, then the recommendation follows the drop in less than 40% only if they're anthracyclines. But if they're not on anthracyclines, then you can potentially continue the same treatment and keep monitoring patients while being on cardioprotective therapy. And then ultimately, if they don't improve or their EF does not recover, then the recommendation is to discuss stopping the cancer therapy. On the other hand, if they're symptomatic, then the additional recommendation on top of cardio-oncology evaluation, starting cardioprotective therapy, is to hold the cancer treatment until you closely evaluate them and they're started long enough on cardioprotective therapy. If ultimately they improve, they're no longer symptomatic, then you can reassess the EF and discuss potentially restarting the cancer treatment. But if they remain symptomatic, then the recommendation is to discuss permanently stopping the treatment and also discussing other alternatives. So some take-home points. Like I said, more patients are surviving from cancer, but they're living with the cardiovascular complications from their cancer therapy, which is equally debilitating and difficult to live with. It comes in many forms. Like I said, it's not only in the form of heart failure. Patients can have arrhythmias, they can have coronary disease, valvular disease. So while it's important to focus mainly on the heart function and it is also important to bear in mind the other possibilities. Surveillance is key. Early recognition is pivotal in preventing a full-blown heart failure from occurring, and initiating cardioprotective therapies on time is essential. And lastly, we should all work as a group. We should all work closely with oncologists, with the patient, with dietitians, and help mitigate this process from happening.
Thank you so much for that really excellent lecture. Great overview of the very complicated topic.
Thank you.
Certainly one of those topics, subtopics could take a whole hour to discuss. So I think that was an excellent overview. I'll turn it over.
If anybody has any questions, please raise your hand and I'll bring the microphone to you.
And if you have questions, you're online, please put it in the Q&A chat box and we'll have our speakers speak to them.
A couple of questions. That was a great presentation, by the way. One is using echo for evaluating chemo-related heart problems. GLS seems to be an earlier indicator than EF. And you also mentioned that they get started places early on therapy, but tended to have a lesser drop in their EF. Do you think it's because people are more prone to treat early with drop in GLS? Or why would the EF have to improve more with GLS than
Thank you. I think GLS guided cardioprotective therapy, over time we learned that GLS drops before the full-blown ejection fraction happens. And as with any disease process in medicine, the longer the stressor is on or the longer it goes on, the more permanent the damage is. So I think the idea is that GLS is an early predictor while there's still some hope for cardiac recovery. So clinicians are more vigilant about that number. They're more likely to initiate the therapy right on time and hence have a more favorable outcome when it is compared to ejection fraction.
My second question, which is at the end, you mentioned that EF was the kind of parameter to look at for initiating therapy, but there wasn't any GLS patients on that last slide. So I kind of wonder if that going to be evolving.
Yeah, so the last slide is concerning, that is when the cancer, when the EF drops to less than 10%, then that is an absolute diagnosis of CTRCD that warrants treatment. GLS is more so when the ejection fraction is still within acceptable ranges, and that's the goal of utilizing GLS, is to utilize it before the EF drops. But this graph here is mainly for patients who have already dropped their ejection fraction.
That's my point, is maybe they want to incorporate GLS.
Right, yeah, that would be something a little bit higher than that.
One last question. Do you think that other EMP is indicated? We'll can answer this. ACE inhibitors and beta blockers, but not MRAs or SIGA, that kind of stuff.
Yeah, I've actually looked that up because I was interested too. There aren't any guidelines incorporating the other two GDMTs in the like if their EF is still normal. But I'm assuming that with any other, heart failure process, once their ejection fraction, then the recommendation is to initiate SGLT2 inhibitors and MRAs. I don't know, Dr. Aglom, if you have any.
In presentation. I thought to go to the slide on tissue and scar characterization.
Those might not be the best images, but the idea is like you would, from the definition, transmural will involve the whole muscle, and then and let me go back. Sorry. Yeah, and then the subendocardial will be, if you can look here, this is the heart muscle here. The subendocardium will be primarily affecting the inner part of the LV, but the transmural LGE will be involving the entirety of the heart muscle.
So, like French to the transfer, I need my cardio.
I think if you come here and look a little closely, you can see here that it's in the mid-myocardium. I think this is not the best software to assess. This is just an example. But on the software, it will be a little bit more clear. You will see it in the middle of the LV versus the transmural, which affects the entirety of the muscle. So in the mid-myocardial, it will be black, white, black. But then in the transmural, it'll just be entirely white.
For those patients who have a reduced EF prior to starting chemotherapy, what options do we have? Do we start Colchis chemotherapy? Do they have to do an alternative therapy? What is the option?
Very good question. I've actually have not thought about that, but from my previous knowledge is that there are some cases where you would start a lower dose of chemotherapy, like you said. Those patients will especially also be have a much closer monitoring process than others. There are also possibilities where you will treat the underlying EF, treat them with GDMT for a while and look for improvement, because most of the times we look at a 3-month interval. So it's not a super long time, but I know with cancer, you won't start therapy as early as possible. But it's obviously a complicated scenario in that case, and it would require the collaboration of multiple people in that case.
Question that came in. I'm just going to read it to you. Great presentation. Thank you. I recently performed a CABG for a patient with history of lymphoma, chemo, and radiation. Treacherous dissection. Patient did well. Any new guidelines for PCI versus CABG and SAVR versus TAVR in this population?
I would be lying if I had researched that question before. I don't have specific information. I don't know, Dr. Aguilar, if you...
Yeah, I mean, I think the main thing I would add is, clearly patients who've had chest radiation, chemos, that sort of stuff, the tissue planes are completely changed, right? When you radiate someone's chest. And as a result of that, you can have valvular disease, as you eloquently pointed out. But, like Dr. Janko mentioned, yes, very tough situation to get in. A lot more risk of bleeding because the tissue planes are just not what they used to be. There's no specific guidelines or data I know about, do we do PCI versus CABG? in this patient population. It's just one of those things I think we take it on a case-by-case basis. If the patient is a reasonable surgical candidate and they're several years away from their oncologic history and they've had a good recovery, and we think their long-term prognosis is excellent, then I think the risk and benefit of surgery probably tilts towards the benefit of surgery. However, I think if a patient who's perhaps still, recently finished chemotherapy, or there's a concern about recurrence, and the oncologist is saying the prognosis is somewhat guarded, but I think if that's the case, perhaps a PCI-based approach or medical therapy may be a better option. But ultimately, to your point, we do need to have a sort of a multidisciplinary conversation with a close conversation with the oncologist to sort of guide us to the prognosis.
Does anybody else have any other questions? We don't have anything else on them.
If not, I have a question. Yeah, so I know you went into great detail with the different imaging modalities: cardiac MRI, CT, nuclear imaging, MAGA scans, biomarkers, if you will. In what scenarios do you prefer to use specific studies? So, are there clinical scenarios that should lead us to our first study, maybe a cardiac MRI, perhaps? Versus other situations where we want to go for a cardiac CT, and so on and so forth. You just point out a few aspects of that, of course.
I think it kind of depends on the geographical location and the clinical scenario that you're working in. I don't know if there is a specific one study that I would choose over the other. I think it's more so of a continuum of studies. So, for example, if someone comes in, the easiest access would be to an echocardiogram. So that would be my first choice always to assess ejection fraction. If over time, while I'm seeing this patient, I see signs that are suggestive of like sarcoidosis, for example, or if I'm suspecting there's another disease process that's happening, like an infiltrative process, then that would lead me to choosing an MRI as well. And then I think cardiac CT will primarily be reserved for patients who have either received radiotherapy in the past, or I think they have coronary disease, and will be a method of non-invasively assessing their coronaries. So I think it's more so of a continuum, and like overall the course of treatment, how it changes, that I would choose the therapy, the modality.
Yeah, no, I completely agree. I think, if someone's an immune checkpoint inhibitor, for example, they come into the hospital with chest pain, certainly our cardiac MRI is going to be pretty high with that. A lot of the talk was focused on sort of preemptively finding early signs of LV dysfunction and then hopefully acting appropriately to mitigate those. Could you talk a little bit more about patients who are in survivorship? So they've gotten their oncologic therapy, they've survived, it was 10 years ago, and now they come to your clinic. How do you talk to that sort of patient? What do you do in that case? So, for example, a lady had breast cancer, had chest radiation and chemo, and has a mastectomy, and now you're seeing her 10 years later. She's completely oncologically doing well. How do you evaluate that patient? What sort of conversations do you have? How do you use your imaging in that sort of setting?
And just to clarify, they have normal EF, or did they?
EF was normal.
EF is normal, yeah. So I think we should follow the same, what the guideline is telling us is to, kind of monitor them. I guess when someone is out of the chemotherapy window and they've been doing well for several years, the monitoring should be less extensive. But I still would advise them to be constantly their self-advocate, be their self-advocate about symptoms. So it's important for, if they start developing shortness of breath on exertion, orthopnea, early signs of heart failure, to be aware of that. I don't think there's a role for, asymptomatic assessment of the heart, like with cardiac MRI, CT, and nuclear, if the patient is doing well and they've proven to have a normal ejection fraction. So it will be mostly just regular physical examinations that will be, performed by either the PCP or the cardiologist. And if they've been doing fine, then the monitoring will be less frequent. And then also focus on all the other comorbidities that can be modified. So diabetes, hypertension, treating anything that could potentially affect their cardiac reserve and lead to heart failure.